Welcome,
Good
Aaron.
afternoon, everybody.
Yeah,
Hi, Steph.
welcome. Strong start.
I was
Usually
just
wait a little bit to get the stragglers in, but it's a very strong start. So I suppose you can start. Yeah.
sorry, I
Wait
just
till
tried,
you enter.
can't get my earphones to stay in my ear. Just give me a sec, otherwise I can't hear. Okay. Good afternoon, everybody. Estelle, I think we can start maybe with a housekeeping while the other
Exactly.
people are
Exactly.
still rushing in.
Yes.
Great. Good
Right.
afternoon, everybody. Thank you very much for joining us on this Monday afternoon's hematology deep dive. And also, thank you very much for allowing Sambus the opportunity to host this session. I think we have a very exciting talk coming up by Dr. Tomek Piokulski, who once tried to teach me how to pronounce his surname. Hopefully, I'll get it right one day. But before we go on with Tomek's presentation, let me just now see. I can't get this. There we go. Just some oh dear, no, it was too many. Let me go back. There we go. Just some housekeeping notes. The recordings of the sessions can be found on the Blood SA website under Resources Deep Dive. We could ask people to post questions and comments in the chat box as we go through as Tommy go through the presentation. Also, please remember to email requests to be added to the mailing list to Melanie at her email address, melanie.davids@uct.ac.za. These presentations are registered for CPD points, which will be automatically submitted to your HBCSA account for each attendee if you are from South Africa. If you are a non-HBCSA registered healthcare professional, for example, a registered nurse, or if you're from another country, you can contact Melanie for the information necessary for you to get CPD certificates. And then in line with standard regulations, 1 hour attendance is required to qualify for the CPD point. So you have to be here, ideally fully present as well, not just logged on for the whole hour for you to get your CPD point. And lastly, on this issue, we do really appreciate your honest feedback. It's utterly useless to present something that doesn't meet the needs of the audience. So constructive but honest feedback on the presentations are always very useful. It ensures that we are able to meet your needs going forward. Then we have some very exciting conferences coming up. The first that I would like to draw your attention to is the International Donor Registry Conference and the World Marrow Donor Association meetings that will be held at the end of June in Cape Town. Very proud that our very own that the Bone Marrow Association of South Africa is hosting this meeting. And then just to note that there is a discounted registration fee for members of Sativa, SACIT, SACOS, and Blood SA. So that's very great. Then also we have the HemOnc conference in September. Also looking forward to that. An important event in our calendars. And then just a reminder of our very capable management team, whom I must really thank for all the hard work that they do in the background. Estelle, Khadim, Melanie, and Bridget. You ladies are exceptionally professional, and I've recently had discussions with not a colleague, a friend of mine who is not at all in the hematology field, is not at all in the blood transfusion field, but who attends the heme deep dive almost religiously on a Monday. And so I think that you guys are doing a really great job at furthering the knowledge of all doctors in the field of hematology and blood transfusion and hematology oncology. So well done. I think with that, I'm going to hand over to Tomek. But maybe just a reminder that next week's talk is going to be on cardiology and hematology. I think a very interesting topic. But for this afternoon, we have Tomek, who has joined Sanbus after he completed his training, and sadly is going to be leaving us again. We will certainly miss his input in a number of areas. But this afternoon, Tomek is going to be talking to us about platelets as a blood product. Tomek, over to you.
Thank you so much, Karen. Just gonna share my screen now. Can I just get a quick shout out from someone with my screen is sharing right and my voice is audible?
Looks great, Tomek, and we can hear you.
Great. All right. Thank you, everyone. This is going to be a fairly technical discussion on platelets as a transfusion product. So a couple of things we'll go through is the different types of platelets, modifications that can be done for platelets, and various transfusion medicine aspects regarding the platelet product. So just briefly, this is some information that I got from a sort of business intelligence interface, looking at the order trends for platelets from about February to August 2023. We had a bit of an IT upgrade, so the data here is a little bit iffy. But if you look here, the red represents apheresis platelets, gray is pooled platelets, and our clinicians are ordering over 6,000 products, platelet products a month, with that being slightly more on the pooled platelet side. In the corner, we see that we are struggling to meet the demand. For example, for pooled platelet products, we have about an average of 115 orders for this time period. We were only able to make 103 of those orders. So we have a chronically slight inability to meet the total demand within the provinces served by Sanbus. The bulk of platelets are ordered in Gauteng, when the bulk of the platelets are used by hematology oncology and the specialist physicians. So as I mentioned, we have apheresis platelets and pooled platelets. So for the benefit of those who might not know, at Sanbus, pooled platelets are made from 5 donor buffy coats. The international trend is to make it now from 4 donor buffy coats, and the Canadians have gone to making it out of 3.5 donor buffy coats. We might hop on the trend. I believe we are busy looking at that. But basically, 4 different donors, we take the buffy coats from those whole blood. We centrifuge them down, take those buffy coats, and make a pooled platelet product. Apheresis platelets, on the hand, are collected from a single donor, and we make all our pediatric units from the apheresis platelets. And then these platelets we cannot just give you dry platelets. They have to be suspended in something. Traditionally, they were suspended in 100% plasma, and some of our zones are still suspending the platelets in plasma. Or we can we can put the platelets into a mixture of platelet additive solution mixed with plasma, and that will be a ratio of about 70% PAS to 30% plasma. And platelet additive solution, there are different brands available commercially, but they all essentially are forms of modified Ringer's lactate. Platelets have to be stored at room temperature. The reason for that is that at the moment you make platelets cold, you partly activate them, and you dramatically shorten their half-life from 7 days to about 24 hours the moment you make them cold. So in order to make sure the platelets last as long in your patient as possible, we have to keep them at room temperature. Unfortunately, that makes them very susceptible to bacterial growth and bacterial contamination. And after 5 days, the risk of bacterial growth on the product is too high, and we have to discard the product if it reaches the 5-day mark. All right, in addition to that, you can also leukodeplete a platelet, irradiate a platelet product, wash it or volume reduce it. And we'll discuss each of those on the later slides. And you can also individualize platelets by matching them for ABO and RH status and HLA and HPA status. And we'll discuss briefly why you would want to do that or the scenarios where you would want to do that. And just to graphically demonstrate pooled platelet production, you have your whole donor unit, which is centrifuged into after centrifuging, it separates into red cells, a buffy coat, and a plasma. And then we take, this is from a Canadian slide, so they were still using 4 buffy coats at the time. But we use 5 buffy coats, and you can take 4 to 5 buffy coats, mix them together, and then you have to add plasma or PAS. And then you have a pooled platelet unit. Now, bear in mind the buffy coat is rich in white cells as well as platelets. So this is a pooled platelet unit, but it's also, technically speaking, a pooled white cell unit. So you want to get rid of those white cells through a process called leukodepletion, and then you'll have a leukodepleted pooled platelet. Apheresis platelets, on the other hand, are collected at the patient's bedside. We take blood from the patient, it's centrifuged in the machine. The machine pumps back the red cells and the plasma into the patient, and the platelets are left behind. As part of this process, the platelets are automatically leukodepleted, and it is a bit more expensive to collect platelets in this manner. These are the sort of very technical specifications that that SANUS accredits us for. So we have to meet these technical specifications at any SANUS audit. But essentially, our platelet products are going to be about 200 mils in volume. Our platelet counts are going to be 2.4 times 10 to the power of 11 or greater, and that's pretty standard for blood services across the world, although the Americans prefer a higher platelet count of 3 times 10 to the power of 11. And if the pooled platelet unit is leukodepleted, it needs to have less than 5 times 10 to the power of 6 white cells. So we don't guarantee they're completely free of white cells, but we do say that they will have below this cutoff. Apheresis platelets are already leukodepleted. And then we also have the 50 ml platelet product for children with a platelet count 0.5 to 0.9 times 10 to the power of 11. Long time ago, we had a sort of intermediate product between the adult and the neonatal product, but that has been discontinued. This is the blood ordering form. So the products that we are talking about now are platelet concentrate pooled, which is non-leukodepleted. So this is a non-leukodepleted pooled platelet full of those white cells. And then you can ask for a platelet concentrate leukodepleted, which by default will be from a single donor, although we do have a little term and condition here saying that if apheresis platelets are not available, we'll try and source a leukodepleted pooled unit. We have the pediatric platelet concentrate that's made from the apheresis unit. You can ask for HLA matched platelets. We'll discuss why you would do that on a later slide. You can irradiate the irradiate the platelets, which we'll discuss on a later slide. We'll discuss washing, although it's not technically a product offered by SANBS at the moment. And you can ask for a directed donation if you have a donor that you know that has a plate. If you have a donor that you know you want to have those platelets for your patient, you can request a specific directed donation. We have a blood administration set that you can get from SANBS. It's a standard blood administration set that you can use for red cells or for platelets. And we used to have platelet administration sets, but those have been phased out. So this form actually does need to be updated. We need to phase out the platelet administration set. And somewhere in here, we need to squeeze in a platelet concentrate pool that is leukodepleted, because we want to start offering that as an option for ordering. So presumably in the next year or so, we are going to update this form and make a new one. All right, so that is sort of briefly what the different kinds of products that we have in terms of platelets, but when would you give the platelets? And you can divide it into the bleeding and the non-bleeding patient. In the non-bleeding patient, you can give platelets if the platelet count is less than 10 to prevent spontaneous bleeding, but you should treat the patient, not the platelet count. If it's a very stable patient, say it's a patient with aplastic anemia who for months has had a platelet count of 8 and they have their tranexamic acid at home and they haven't really had problems with bleeding, it's probably not worth transfusing the patient. On the other hand, if it's a patient that you're about to give another cycle of chemotherapy for and the platelet count's already at 8 and you know that chemotherapy is going to knock the platelet count down to 0, then that is an ideal candidate to have a prophylactic platelet transfusion purely because of a very low platelet count. Once you want to start doing a procedure on the patient, you need a slightly higher platelet count. So if you're going to do a procedure that's not associated with blood loss, such as a central line placement or a chest drain, you probably need to maintain a platelet count of 20 or more to maintain the hemostasis. So if the platelet count is less than 20, you should probably order platelets for the patient. If a patient's on anticoagulants and for some reason the platelet count has dropped below 30 and you cannot stop or reverse the anticoagulant, these patients are at very high risk of spontaneous bleeding once the platelet count's less than 30. And at that point, you should consider transfusing prophylactically and keeping the platelet count above 30. For a lumbar puncture, you need a platelet count of above 50 and at least 50 for epidural anesthesia, but with that guideline and with all these recommendations, you need to correlate with appropriate society guidelines. So with regards to epidural anesthesia, the Swedish Anesthesia Society says 50 is fine. Most of the mainland anesthetic societies say you need a platelet count of 65. The Americans say you need 75, and the British are sticking with the old cutoff value of 80. So somewhere between 50 and 80 is the safe cutoff limit for epidural anesthesia, and the experts are still arguing about where that limit might be. Once you're going to do a procedure of major, that's going to have significant blood loss or anything that you consider major surgery, you need a platelet count of more than 50. However, if you're going to operate on the head or spine, you need a platelet count of 100 to maintain hemostasis in the central nervous system. Those are the adult values. For neonates, the values are a little bit different. So for term infant, for platelet count of less than 20, you are justified in giving a prophylactic platelet infusion to prevent spontaneous bleeding. And those cutoffs go up to 30 and 50 for the preterm neonate, who is more than 7 days or less than 7 days old, respectively. For neonatal alloimmune thrombocytopenia, their platelet counts can crash to the floor quite quickly, so you want to keep the platelet count above 30. And then otherwise, if the baby has a coagulopathy or a history of significant hemorrhage, you would opt for a higher cutoff of 50. But otherwise, as with adults, for surgery or major procedures associated with blood loss, you need a platelet count of more than 50. And for anything on the central nervous system, you need a platelet count of more than 100. So those are the non-bleeding sort of cutoffs. What about the patient who is bleeding? So any patient who has severe bleeding, which is WHO grade 2 or above, and I looked it up, what does WHO grade 2 actually mean? And in essence, it means any bleeding that you as a clinician think is significant. So if you think that this is severe bleeding by virtue of the fact that you're a clinician, it's automatically WHO grade 2. So you would want to maintain a platelet count of 50. However, if there's multiple trauma or injury to the central nervous system, you want a platelet count of 100. That said, there is one exception to this rule. If you have an intracranial hemorrhage and your patient is on an antiplatelet drug, such as an aspirin or clopidogrel, if you give platelets too early, the one study showed there are worse outcomes if you give platelets early. You actually have to wait for the antiplatelet drug to wash out of the patient before giving platelets. There is a sort of gray zone. If the bleeding is clinically significant, but you don't think the patient needs platelets immediately, you want to try other things first, such as perhaps giving IV tranexamic acid or perhaps nasal packing to control a nosebleed, there's a gray zone between 30 and 50 where you'll probably manage hemostasis if the bleeding is not too bad, and you can play around with another intervention before resorting to platelets. And the big exception to these cutoffs is for patients known or suspected to have a platelet dysfunction disorder, because these patients can have a normal platelet count and the platelets are completely dysfunctional, and therefore the platelet count is not a reliable guide to transfusion of platelets. So there you would treat for clinical response rather than according to a platelet cutoff. So those are the times you'd want to give platelets, but there are specific scenarios where you don't have to give platelets. So patients with ITP, without major hemorrhage, even if their platelet counts are close to the floor, if they're not bleeding, they don't need platelets. If you transfuse platelets, they'll be destroyed in a matter of hours. So you're really just treating yourself as the clinician rather than the patient if you transfuse an ITP who's not bleeding, even if the platelet count's very low. If a patient is getting platelets as part of the preparation for a procedure, you should give the platelets within 6 hours of the beginning of the procedure. If there's going to be a delay of more than 6 hours, rather delay the transfusion until, and ideally give it as close to the procedure as possible. As I mentioned, if you're doing a minor procedure and your platelet count is low, but it's above 20, and you want to put in a chest drain or a central line, you don't need platelets if the platelet counts more than 20 for a procedure associated with minimal blood loss. And it's not really necessary to give platelet transfusions, even if your platelet counts less than 10 for a bone marrow aspirate or trephine biopsy. If you're inserting a central line peripherally, if you're removing a central line or you're doing cataract surgery. As a substitute for platelet transfusion, you can use good technique and other hemostatic measures, perhaps have an extra pair of hands. So if you're doing a bone marrow, you have an extra pair of hands just to put pressure for 15 minutes after the procedure. Even with very low platelet counts, these procedures are not associated with significant bleeding, provided good technique has been used. All right, so I want to now compare apheresis platelets with pooled platelet products. So I'm not, or filtered pooled products. I'm not comparing the non-filtered pooled platelet product that you can order on the blood form, but rather the one that we are thinking of introducing more frequently. And really, they are essentially the same with the same hemostatic benefits. There was once it was thought that perhaps alloimmunization risk might be higher with a filtered pooled product, but studies have shown that the alloimmunization risk between apheresis and filtered pooled products are essentially the same. Risk of adverse events are essentially the same. The major issue is that you have a theoretical risk of increased donor exposure for infectious for transmission, such as, for example, HIV or hepatitis B, that can be transmitted from a donor to a patient. But that is a theoretical risk. So in order to reduce that risk, we do nucleic acid testing, which has fairly small window periods, although it's still technically possible for a donor to present for blood donation and be in a window period where our testing methodologies will not pick up the infection, but technically the patient can transmit the infection. But we test our products for HIV, hepatitis B, and hepatitis C, as well as for syphilis. And then a further sort of thing that we do in order to make our pooled platelet product exceptionally safe is that at the moment we only manufacture pooled platelets from what we call our category C donors. These are donors that have donated at least 4 times in the previous 24-month period, and our stats show that these donors are exceptionally unlikely to suddenly present with an HIV or hepatitis B. Generally, these are donors that take their health quite seriously, and we have a good track record of negative results from them. And in terms of transmission of infection from platelet products to patients, since the 3rd of October 2005, when we started nucleic acid testing, we have no record of any patient having been infected with HIV or hepatitis from a pooled platelet product, or any platelet product for that matter. And this is not just true for SANBIS, but is also true for other blood services. There's no other blood services have found the same thing, that they've not really had transmission of infection via the pooled platelet products. Although those we're talking about settings that do have much less risk of HIV transmission, but in Western settings and in SANBIS, the pooled platelet products are not associated with increased risk of infection transmitted from donor to patient. In the long-term future, pathogen reduction will make pooled platelet products even safer. So pathogen reduction is still too expensive for SANBIS to roll it out universally. Hopefully, the technology will get cheaper and cheaper, but pathogen reduction destroys anything that has DNA in the product. So that would be ideal to make a product exceptionally safe in terms of not only preventing in transmission of known infections such as HIV and hepatitis B and C, but also for destroying pathogens that might not be known as yet. All right, so these are our state prices for platelet products. So platelets are not cheap. A single apheresis unit of adult unit of platelets is 14,500. The pediatric units are 3,000, and a pooled non-filtered platelet products is 10,600 Rand. If you had to add the cost of filtration to the pooled product, that adds about 2,700 Rand to the cost. It's still about 1,000 Rand cheaper to give a filtered pooled platelet compared to the single donor apheresis product. Now, there was a long-standing myth that apheresis platelets are much safer than pooled products. And that even if you have access to filtered pooled platelets, you should still choose apheresis platelets. But that, as I said, is a myth. There are only three sort of absolute indications where apheresis platelets are definitely preferred above the filtered pooled platelet product. And the first is when you need a matched product for refractory thrombocytopenia. So this is a product that has to be HLA or HPA matched, and you really want to just get that from one single donor rather than trying to match four Buffy coats to get the match. Neonatal aluminum thrombocytopenia is essentially a disease of anti-HPA antibodies, so it's essentially the same as the previous indication. It needs to be an HPA matched product. If you're in a blood service that maintains a register of donors that are IgA deficient, you can also request an apheresis platelet from an IgA deficient donor in case you have a patient who's IgA deficient and you suspect that patient might have an allergic reaction to IgA. Unfortunately, that's not currently an offering at SANBIS because we do not maintain such a register. A relative indication for apheresis platelets is that it's just much easier to make neonatal and pediatric units from a apheresis unit. And relative contraindications to apheresis platelets, in other words, where you would rather have a filtered pooled platelet product instead of an apheresis product, is if you're doing a non-ABO compatible platelet transfusion. Because the apheresis products are associated with a slightly higher incidence of adverse events. And if you have a patient who's got a platelet refractory state, but you're still waiting for the HLA and HPA antibody antigen workup, so that's still pending, but you need to give platelets right now, it's better to give the leukodepleted pooled platelet product. You get a slightly higher platelet increment and they last for a little bit longer. And it's thought to be perhaps due to the fact there's multiple Buffy coats with multiple different mixes of HLA and HPA antigens, confusing the patient immune system and allowing some of those platelets to escape. All right, so what is the dose of platelets that you would give? So if you're more than 15 kilograms, 1 unit of pooled or apheresis platelets is usually adequate, and below 15 kilograms, you're going to go for a dose of 10 to 20 mils per kg. And that should increase your platelet count by about 35 to 45 by 1 hour post a transfusion. You would give them through the standard administration set. You would give it over about 30 minutes, and you need to give it within 6 hours of issue from the blood bank. However, it should be a clean administration set. Do not use an administration set that has already been used for blood, as that will activate the platelets and dramatically reduce your half-life. And if there's a delay in transfusing into the patient, please don't put the platelets into the fridge. You need to keep them at room temperature. The moment you put them in the fridge, you start activating the platelets. All right, so there are times you would want to ABO-RH match platelets. Not routinely, it's not required, strictly speaking. You don't have to ABO-RH match the platelets. However, if you do ABO match platelets, you can extend the platelet lifespan, and it's associated with a higher platelet increment. The other issue of ABO mismatching is that it's been rarely reported to cause hemolysis in a patient, and that's due to antibodies present in the plasma within the platelet product. So that will be donor antibodies reacting with patient red cells causing hemolysis. Also, platelet products can be contaminated with red cells, and an RH mismatch can cause alloimmunization of anti-D, in particular with pooled platelets, although there have been cases described of alloimmunization due to apheresis platelets as well. So in the ideal world, you would always want to match your platelets to the ABO-RH status of the patient, but the fact of the matter is we don't have enough stock for that to be routine practice. So if you want to have ABO-RH matched platelets, don't order it routinely, but consider for the context of the patient whether it's important for it to be an ABO-RH matched product. So if platelet lifespan is very important in your care plan for the patient, rather ask for ABO matched platelets. So an example, a potential scenario where that could happen is if you have a patient with aplastic anemia, very low platelet counts, but they need to go in for surgery that's unrelated to aplastic anemia, and you want their platelets to last a little bit longer so that they can heal from their surgery, that would be a good opportunity to ask for ABO matched platelets. And ABO matching can increase the lifespan of platelets in the patient from about 7 days to even up to about 10 days. So you have a few extra days and a slightly higher platelet increment if with ABO matched platelets. If you need to avoid hemolysis or the patient's very anemic and you're worried about those plasma antibodies that could potentially match, or could potentially cause hemolysis in the red cells, then you can also ask for ABO and RH matched platelets or ask for O negative platelets. If you have a female of childbearing potential, ideally you should always give RH compatible platelets. You can give anti-D immunoglobulin if incompatibility is unavoidable, although that's only recommended in females of childbearing potential, simply because alloimmunization with anti-D tends to not be that clinically significant in males and in females who are not going to have children. The main issue is that we want to avoid hemolytic disease of the newborn. And because of chronic inability to completely meet demand, sometimes you just have to use the platelet product that we have available. So you do sometimes have to bend your rules if there's no product available, in particular if the need is urgent. Just speaking about anti-D administration, generally international guidelines look at the data for how much red cell contamination is present in the platelet products and then make the guidelines from that. We don't have a South African guideline. In SANBS, we do not monitor our platelet products for red cell contamination. All we can tell you is that if there's no visual contamination, it should be less than 0.5 mils of red cell contamination, but even a tiny amount of red cells can cause alloimmunization. Now, the British Blood Services manufacture platelets more or less the same way we do, and I think we can safely use the British guideline in terms of anti-D administration with regards to platelets. And they say a dose of 250 international units of anti-D immunoglobulin is sufficient to cover 5 platelet products of D-positive platelets given within a 6-week period. So the half-life of that anti-D is long enough and the dose is high enough. You can give 5 doses of RH positive platelets to an RH negative woman within a 2-month period, and that one dose of anti-D should be fine. In South Africa, we have Resugam, which is a bit of a higher dose at 500 international units. So that will be enough to cover you for this scenario. Bear in mind, if a patient is very thrombocytopenic, with a platelet count less than 30, you shouldn't be giving intramuscular injections. In that case, you can either give the anti-D subcutaneously, or you can give the platelets first and then give the anti-D. You have up to 72 hours to give the anti-D. So you can give the transfusion, and even if you give the anti-D the next day, you should be fine. All right, so I'm going to talk about product modifications now, starting with leukodepletion. Leukodepletion, essentially, we use gravity to move platelets from one bag through a filter into another bag, and this filter is designed to capture white cells. Leukodepletion has to be done fairly early in the processing or in the production of the unit, as the white cells quickly die off, and then once they've died off, those apoptotic fragments will go through the filter. So you have to capture the white cells while they're still whole. And we remove the white cells from that buffy coat, so there's going to be less HLA molecules. It's going to be less inflammatory mediators released by activated and dying white cells, and there's less risk of passenger viral infections, in particular cytomegalovirus, and theoretically also Epstein-Barr virus and HDLV. Proven benefits of leukodepletion is that there's reduced febrile reactions of the non-hemolytic variety, and that makes sense because you have less inflammatory mediators. You have decreased CMV transmission, and you have decreased HLA sensitization, since it's the HLA molecules on the white cells that are more likely to cause the sensitization. And indeed, leukodepletion of a pooled platelet unit makes the sensitization risk to HLA equivalent to an apheresis product. And this is the landmark trial that showed that the pooled platelet unit is equivalent. So which patients should receive leukodepleted components? That would be patients who are on a chronic transfusion regimen, patients who are at risk of cytomegalovirus infection, patients less than 1 year old, and this nebulous term of anyone who is critically ill. All right, so just to briefly mention, in terms of availability of leukodepleted pooled platelets, if you're excited about the product and want to order it, please note that we are still in the process of rolling it out through SanBus. At the moment, KZN and the northern parts of Gauteng can provide leukodepleted pooled platelets, and we're busy rolling it out in the Free State, and we'll see how well we can roll this out. We can irradiate a platelet product for you using X-ray or gamma ray radiation, and the main purpose is to kill lymphocytes, but it does kill some pathogens, so it does partly sterilize the product. And there's only one indication for irradiation, and only one, and that's to prevent transfusion-associated graft versus host disease. In other words, we want to prevent donor lymphocytes from multiplying in the patient and then attacking the patient. And there's a list of specific scenarios where patients are particularly vulnerable to this complication. And that would be your intrauterine transfusions, your T lymphocyte immunodeficiency syndrome, stem cell transplant recipients, and patients receiving various chemotherapy modalities and Hodgkin lymphoma, and also directed donations because lymphocytes from first and second degree relatives are more likely to escape patient immune system mechanisms aimed at removing those lymphocytes, they at higher risk of graft versus host disease. So that's irradiation, which is likely to be replaced once we have pathogen reduction, because pathogen reduction kills anything that is DNA in the product, and because lymphocytes have DNA, pathogen reduction kills off lymphocytes. So in blood centers that have adopted universal pathogen reduction of their products, of their platelet products, there's no need to irradiate those products anymore. All right, you can wash a platelet. So I mentioned that even if you use PAS, you're still going to have a bit of plasma in a platelet product. Now, what do you do if a patient's had a severe allergic or anaphylactic reaction to a platelet product? Well, the reactions usually due to something in the plasma, so you need to get rid of as much of that plasma as possible. And you can wash platelet product. Essentially what you do is you centrifuge the product, remove the plasma, the supernatant, and then replace it with more PAS to get the plasma content down to 3%. which in the literature has pretty much been shown to reduce the risk of recurrent severe anaphylactic reactions to essentially zero. I couldn't find any case studies or reports of patients receiving washed platelets and still having an anaphylactic reaction. That said, it's not good for the platelet product. You wash out a lot of the platelets into the product, you can lose up to a third, and it does partly activate and damage the platelets. So your platelet increment and your platelet lifespan are all going to be affected. As such, we do not recommend washing for mild or even moderate allergic reactions. Rather, treat the patient with antihistamines and steroids. Washing of platelets should be reserved only for life-threatening anaphylactic reactions. And as such, this product is not officially part of our service offering. If you do think that the patient needs a washed platelet product, you must please call one of the SANBS doctors and discuss your particular scenario where the washing of platelets is an appropriate thing to offer. Another product we don't offer is a volume reduced platelet product. And I don't think we've ever had any requests for this, but for the sake of being of completeness, I'm going to briefly discuss it. And essentially, you can centrifuge a platelet product and remove that plasma supernatant or the PAS plasma supernatant. Alternatively, you can ask for a platelet concentrate to be collected with apheresis and ask them not to give any additive solution to that. And that would give you a platelet product that has less volume. So the major indication is for the volume overloaded patient that you as a clinician suspect that even a small increase in intravascular volume is going to be bad for this patient. And where it has been sort of best documented in terms of use cases is in the neonatal and the very small pediatric cases. So generally, not all blood services offer this, and the blood services that do offer it tend to offer it to very sort of specialist neonatal units. There's a theoretical reduction of risk of incompatible anti-ABO antibodies. So theoretically, there's a reduced risk of platelet-induced hemolysis. And because you're removing plasma in the product, theoretically, you should have less of an allergic reaction to it. It might be suitable for mild to moderate allergic reactions, although it wouldn't remove enough of the plasma to be a true alternative to washing. You do lose platelets when you do volume reduction, and the centrifuging process does cause platelets to aggregate and start to activate. So you do have issues with you do have reduced platelet increments and platelet lifespan due to the process. And as I mentioned, this is not officially part of our service offering. So those are the modifications you can do to platelets. Now I want to move on to the concept of platelet refractoriness. And that's if you've given your patient a platelet product, but the platelet count has refused to go up, you might start suspecting that the patient is platelet refractory. And that's defined as a repeated suboptimal response to platelet transfusions with lower than expected post-transfusion count increments. Now, in about 2/3 of cases, this is due to an anti-HLA or anti-HPA antibody, which is binding with the platelets and rapidly removing them from circulation through an immune-mediated mechanism. However, you can also get a pseudo-refractoriness, and that happens if you're giving too few platelets into too big a patient. So most of the literature on platelet refractoriness recommends that you should confirm that the patient truly is platelet refractory by doing a corrected count increment, which is this formula here where you take the post-transfusion platelet count minus the pre-transfusion platelet count multiplied by the body surface area, and you divide it by the amount of platelets transfused, and that you'll have to get either from the platelet bag, or you have to phone blood bank and just ask them that for those platelet units that were issued, what was that platelet count for that specific bag. There are online calculators where you can just plug in the numbers and it will give you a result. And if your corrected count increment is less than 7,500, that is by most sort of studies considered to be diagnostic of platelet refractoriness. So having diagnosed your patient as being platelet refractory, the next step is to ask a blood bank to do some tests. You're going to take a patient sample and send that sample, and in the comment box of your blood ordering form, you're going to ask them, please, on this sample, do an HLA phenotype, do HLA antibody typing, and do an HBA antibody screen. And please send the results to me on my email address, so and please call me on my cell phone, such and such. So I do recommend, whenever asking blood bank to do tests, always put your details down clearly, ask them to contact you so that the results don't get lost somewhere in our blood bank IT system. All right, but if you send those results and we call you back and we tell you that the HLA antibody results are out, and indeed the patient does have an anti-HLA antibody, then at that point, in order to get platelets that actually do their job in the patient, you're going to either have HLA matched platelets, and these are platelets that are completely identical to the HLA profile of your patient platelets. Or you can ask for HLA antigen negative platelets, in particular if it's urgent and searching for an apheresis donor who's a 100% match might take a long time. HLA antigen negative platelets will mean that the platelets are not the same as the patient platelets. However, they are negative for the specific antigen that the patient has developed an antibody to. And essentially the same issue with if you have a human platelet antigen antibody. If it's a huge headache to find an HLA matched or HPA matched product, sometimes you'll get lucky with donors that are close relatives of the patient, because they're more likely to have a similar HLA mix. So you can, this is a scenario where you would consider directed donations, bearing in mind that the product must be irradiated. However, if the patient is one of those 1/3 of cases where no antibodies are detected, you need to search for other causes of platelet loss, such as an ongoing DIC or hypersplenism, because it wouldn't be helpful to match platelets if there are no antibodies. All right. So you're giving a platelet transfusion. Are there risks? Of course, there are risks. You can get any transfusion-associated complication or side effect that you can get with other blood products. And in fact, platelets are the most likely product to cause a transfusion reaction. The most common reactions are the febrile non-hemolytic transfusion reactions, which is due to the high white cell content and high inflammatory cytokine content of platelets, and allergic reactions, which are due to the platelet. Due to the plasma component. So you can reduce the febrile non-hemolytic transfusion reactions by getting leukodepleted products, and you can reduce allergic reactions by specifically stating you want a product that's mixed with PAS rather than 100% plasma. And platelets are uniquely high risk for bacterial contamination. So rather than having risks of infectious transmission from donor to patient, we actually have a much higher risk of transmitting bacteria that have grown de novo in the platelet product into the patient. So we do occasionally have issues with sepsis that is triggered by a platelet transfusion. So we do bacterial monitoring of our platelet products. We do take cultures on our platelet products, but we do have occasional situations where the cultures come back positive. We try and trace the platelet product that has already been transfused into the patient, and then we have to deal with that on a case-by-case basis. Now, you don't always have to give platelets. You can consider alternatives, starting with lifestyle measures. If you have a person with a low platelet count and they have regular nosebleeds, you can advise them to keep the nasal mucosa hydrated by giving them a saline spray or even putting Vaseline on the nasal mucosa. They should know first aid measures, how to control bleeding, especially epistaxis. And these patients should know they should avoid contact sports. They should avoid medications such as NSAIDs and aspirin that suppress platelet activity. They should preferably abstain from alcohol because alcohol suppresses platelet production as well as suppresses platelet activity. And they should have adequate nutritional support. And in some cases, for the right patient who's got low platelets, they might be able to control their bleeding risk just with lifestyle measures rather than regular platelet transfusion. You can use pharmaceutical agents in place of platelets. You can decrease fibrinolysis by giving tranexamic acid. You can increase von Willebrand factor levels by giving desmopressin. You can optimize platelet adhesion by treating the anemia. With anemia, you have less viscosity and a high pulse rate, which prevents adequate platelet adhesion. So perhaps a red cell transfusion might be able to, or treating a nutritional anemia might be enough to optimize the platelet adhesion. You can increase the formation of cross-linked fibrinogen, and there are various ways of doing that. You can use activated recombinant factor 7 or recombinant fibrinogen. Our product that is rich in fibrinogen that we offer through Sanbus is cryoprecipitate. And cryoprecipitate has been recommended by some experts as a potential second-line treatment for patients who need platelets, but for whatever reason they cannot get the platelets. Perhaps they have some sort of reaction to platelets, or they're in a setting where platelets are not readily available. And you can stimulate endogenous platelet production through thrombopoietin mimetics. Right, so possible things to look out for in the future from Sanbus and from platelet products in general. Perhaps we are looking at the possibility of decreasing our pooled platelet unit to 4 units, as is the international trend, and as I believe Western Cape Blood Service has already moved on to a 4-unit pooled product, and that will greatly increase the amount of pooled platelet products we can offer. Because our apheresis platelets because we have constant short supply of apheresis platelets, we would like to supplement the uptake of that by offering leukodepleted pooled platelets as an alternative, especially where apheresis platelets might not be available. We are doing research into frozen and cold stored platelets. The half-life of these products is very short, so it only lasts about 24 hours on the patient, but for acute bleeding, that's enough to control bleeding. So these have been pioneered in sort of trauma settings and military settings just to control acute bleeding. And that might be a product we could offer for the casualty setting, perhaps. We want to try and decentralize processing of our products. So we've done a pilot study on the Reveo system, which is a miniaturized production facility, whereby we can take whole blood and quickly make it into its various components. So at the moment, for example, if you donate blood in Kimberley, that unit has to travel to Bloemfontein. It's processed in Bloemfontein. We make the platelets, pooled platelet product in Bloemfontein. And if you need a pooled platelet product in Kimberley, it has to be shipped back. So some of our supply lines are quite long, and we want to try and reduce the logistical challenge of getting the needed products to where they need to be. Once the technology is cheaper, we'll probably introduce pathogen reduction, which would eliminate the need for irradiation. It would extend the shelf life from 5 to 7 days, markedly decreases infection risk and bacterial contamination, not only of known pathogens, but also potential unknown pathogens that might arise in the future. And we have taken very tentative first steps to grow platelets. So I know in particular the Japanese are making great strides in growing platelets in a lab, and we have taken some very tentative first steps at setting up a platelet growth lab. Very early days, but the idea is that we don't want to really be caught behind once blood products become manufactured from laboratories rather than manufactured from donor blood. We want to play a role in blood transfusion, even if technology advances. And the pharmaceutical companies are trying to figure out how to replace platelets. So the technology that's currently showing the most promise is the procoagulant nanoparticle, which mimics platelets. And there's currently some preclinical research being done in animal models that is showing promise that these nanoparticles can actually take the place of platelets and maintain hemostasis. These are all my references, which I can provide on request. And that is essentially the end of my talk. And I hope that was helpful in some way or other. And yes, I guess we can open for comments and questions.
Thank you very much, Tomek. That was very, very quick whirlwind through a ton of detail. So thank you very much for that. maybe just as a quick reminder while we see if there are any questions, a reminder, please, to complete the Survey Monkey. It is both in terms of CPD points, but also importantly for SANBIS, for our records. And then what else is there that I can see? There's a question on, are the patterns of platelet use prescriptions similar in public versus private hospital use? Tomek, do you want to have a go at that one?
Sure. I don't remember the exact numbers, and I must say I didn't dive into that very deeply. But the trend seems to be that the public hospitals are main consumers of the non-filtered pooled platelet product, and private it's more the apheresis single donor product. But you're welcome to correct me, Karen, if that's not the correct data.
It's it is quite, yeah, that is correct, yeah, but there's also a difference in the patient population. So in the public sector, the age group and gender that uses platelets the most are young females of childbearing age, whereas in the private sector it is older males. And we suspect that it is related to the underlying pathology, young women of childbearing age. Suspect that it is related to obstetric complications, certain oncology or cancers are common in that age group. Whereas with the older males, again, I think it's oncology driven. So one of our colleagues at the Stellenbosch University, in collaboration with some of us at the at SANBIS, just finalized a publication on this, which we will be submitting soon. But very interesting that the difference in utilization between the public and private sector, very similar to the difference in red cell use between the two sectors. Other question, what was this one? Sorry, I can't quite see. There was a question about frozen platelet products. So I think that one has been answered. I agree, Vernon, a review article on the topic would be really great. And then, Benny, what did you have? Just a lot of excellent talks. I think there's one new paper, 1997 paper on pooling of platelets. So Vernon, this is the question about the risk of pooling 5 units versus the pooling or the use of a single donor apheresis product. So one of the key risks is that if you pool 5 donors, you are exposing that recipient to the immune system of 5 donors, but also to the risk of transfusion transmissible infections from 5 donors, which was why in SANBIS it drove the policy that we have currently still, that we only make pool platelets from people who have donated at least 4 times in the last 24 months, because they are at very low risk of suddenly becoming HIV or hepatitis B positive. However, that has created an artificial shortage of pool platelets in South Africa. And so, or in SANBIS rather, and we are actually at the moment looking at revisiting this, specifically given what has happened to the trends of HIV prevalence and incidence in SANBIS over the last decade or 2. So yeah, interesting conversation, that one.
Karen, if I may comment on that, so I think the question, that New England paper from 97 that showed that the two were equivalent. I think my concern is the bacterial risk that we know is relatively high. We've seen, the data on the chances of a platelet unit being contaminated during the donation process. And we're not adding ultraviolet irradiation as they did in that particular trial, if I've got my facts right. So can we really say that these are equivalent bacterial infection-wise in our setting? I agree with you. I think the steps taken to abrogate the risk for other TTIs, perfect, very good, but it's more the bacterial infection risk I'm concerned about.
So there's an
Of-
interesting paper that was done, and even our data in Sandbus show that there's a higher risk of bacterial contamination in apheresis platelets that are leukodepleted at source. So they are leukodepleted at the time of collection versus pooled platelets that are not filtered. And it is postulated that that is in part because with the pooled platelets, you still have a lot of white cells in there, and they kind of take care of any little organisms running around, the bacterial organisms running around. So there is some really nice data on this to show that the bacterial risk of pooled platelets are actually not higher than for apheresis platelets. But that is unfiltered pooled platelets. We would obviously continue to monitor this if we start filtering, because as I said, the hypothesis is that it's the circulating white cells or the pooled white cells that are there with the platelets that actually help reduce the number of bacteria.
So that's very interesting. If you say the risk is higher, is that risk then calculated based on a pooled versus an apheresis, or a whole blood from which a buffy coat is taken versus an apheresis?
We sample the apheresis. So we do quality control checks on certain quality control checks we do on every single collection or a product, and some we do on like 1% of the production.
Okay.
So we test 1% of apheresis platelets and 1% of the pooled platelet.
Okay, so it
not
is the
whole blood,
combined.
It
Okay,
is yeah.
interesting.
And this data was replicated elsewhere. It's not just in Sandbus that we've seen this. Other people have published on this. I was completely surprised. I thought when we started the pooled platelet bacterial screening, I thought we were going to have horrendous numbers. And then when it turned out to be much better, we looked in that, which we should have done, I think, to start off with. But we then went and looked and saw that other people have found similar results.
If I may ask another question, if you do not filter initially or immediately, are you not running the risk of white cell nanoparticles expressing HLA staying behind or building up in your product in that period that you're waiting to leukapheresis?
Yes, and that is exactly why I would be a little bit worried about the bacterial risk of the filtered pooled platelet, because we would filter at the time of production. And so it would be interesting for me to see what happens to the bacterial risk if you remove these white cells now, right at the time of production. So there would still be about, probably about 18 to 24 hours from the time the blood was collected until this pool is made and filtered. But I think that is still sufficiently short a time before the white cells really start degrading. But definitely You're going to, if you filter too late, it doesn't matter anymore because the white cells have already started deteriorating. And if you filter very early, you may potentially lose the protective effect of those white cells. So we would have to, when we start this, we'll have to keep a very close eye on everything.
Thanks, Karen. I see there's a few other questions, so I'll be quiet now.
There's how relevant is the improvement of the platelet count compared with just observing that the bleeding has stopped or not started? Tomek?
I mean, I wouldn't say that you're treating to a target. Even with red cells, I would advise clinicians not to treat to a target because there's this habit of doing a post-transfusion count, which is not always necessary. But yeah, I mean, if your patient has improved and the bleeding has stopped, and you transfuse because the patient was bleeding, I don't see the value of doing a post-transfusion count. You've achieved your aim, and you're just reducing you're just taking blood out of the patient. So no, I don't think it's of value to treat to a target in a setting of an acute bleed. Where you treat to a target, I think, is if you're getting the patient ready prior to a procedure, because there you would want to make sure your platelet count is at its minimum. But and for that particular scenario, if the bleeding has stopped, I don't know what value to do a post-transfusion platelet count for that particular scenario, unless you're worried about the patient rebleeding or there's some other risk factor. And again, I always treat the patient, not the platelet count. You as the clinician, if you think that the bleeding is under control, it probably is under control then. But again, correlate that with the guidance. I mean, if the Anesthesia Society of South Africa says you must give a platelet count, you have to have a platelet count of a minimum of 80 to prevent complications from the epidural procedure, then rather go with that guidance. But from a pure sort of transfusion medicine perspective, I think your clinical judgment is probably as good as of FBC. That said, I'm not a very I have had experience in emergency medicine, a little bit of experience, but I wouldn't consider myself an emergency medicine expert or bleeding expert. So please take my words with a little bit of a 2 cents.
Thanks, Tomek. I think your answer is perfectly reasonable. You are treating to stop the bleeding or prevent it from starting. So if you've achieved that aim, the actual circulating platelet count is, I think, less important. I'm sure Prof. Marius will agree with that. Then Barrick asks, how often are platelet donors in South Africa allowed to donate? Is it different at all from other countries? I don't know, Tomek, if you can you
I stand to be corrected. Remembering off the top of my head, I believe it's every 2 weeks. Although you can be welcome to correct me, Karen, if I'm wrong. And from what I've seen, that's pretty standard practice for platelet donation in other settings. I don't think there's any reason to deviate from that. I do think some centers I have looked at some research articles where they pushed the time interval to be a little bit shorter. I don't think anything conclusive has come from that research.
No, that's correct. Most countries that I'm aware of will have a donation frequency of something to the order of once every 2 weeks. In some countries, they will allow you to donate once a week, but then no more than 24 times a year. So kinds of still come back to the once every 2 weeks. You can, under certain circumstances, we have done this, for example, where we have a need for HLA matched platelets for a stem cell transplant patient or so forth. You can donate a few times in succession every 72 hours, but that's under very, very limited circumstances, and those patients you would then leave to, or rather donors, you would then leave to not donate for quite a while. But in this instance, our policies are very much aligned with the rest of the world. We did have at one point, we had a policy, but this is going back probably about 8 years ago, in Sandbus, that people only donated once a month. But we aligned that to international practice some time ago already. Okay. I'm not seeing any questions. I don't know if I've missed anyone. If we have no other, oh, there's a new message. Thanks, Karen. Okay. If we have no other questions, I'm going to say thank you very much to Tomek for doing this for us. We really appreciate it. It's very informative, and I want to thank everybody for attending, and for Blood SA for making it all possible, and everybody to enjoy the rest of the evenings. Thank you.
Thank you, everyone. Have a good evening.
Bye-bye, everybody.
Bye-bye. Thank you.
Great stuff.